I'm delighted to be here. I've been asked to talk about the integrated care models for frail elderly. Despite the cross-national differences in the way we, culturally certainly, but the way we organize, finance, and deliver care for older people and indeed for people who are chronically ill, have medically complex conditions. We all seem to have the same problem. Still, people who have these complex needs, these special needs, people who are vulnerable, people who are frail, of young or old, fall in the cracks. They don't get the care they need. They don't find the care they need. There's access, continuity, and coordination problems. There's care of burden and stress, the families who play an important role in the lives of these frail elderly. And then finally, they're relatively difficult to manage and costly. People say we can't afford the system, and yet we have increasing need and increasing demand. There are many weaknesses in this system of care. It's not so much long-term care, but the system of chronic care for these complex populations. There's greater emphasis on cure versus care. There's fragmented, misaligned policymaking, planning, regulation, and financing. There's imbalances between institutional versus home and community-based resources, community care, I guess you would say, in your country. Poor collaboration at the organizational and provider levels within and between health and social care and other kinds of sectors. And there's a lack of a single provider team and or entity with responsibility for care and outcomes, and that's the crux of the matter about how one begins to solve this notion of how to best organize and deliver and afford services for frail older people. And so integrated care and integration is the offered solution to this problem. It's very intuitive without being a scientist or a health policy analyst or a researcher or a clinical person. The notion of tying up this messy system, these messy services into one nice, neat package with a bow is very attractive. It's attractive to those who want an accountable, affordable system of health and social care. It's very, very important, first and foremost, to family members and those who have these complex needs. And it's also of great use and importance to those who deliver care. The idea of working together, you call it, you have great words, so you joint working and partnership working, better ways of working together around the needs, the complex needs of these patients, clients, or users, as you would say. My colleague at Brandeis University, Walter Lutz, who kind of tried to clarify the various ways one can achieve integration, integrated care. He says there were three kinds of, in his framework, there are three ways of integrating care. There's linkage, the least change method of bringing providers and institutions together around the needs of a client or patient. It's not very transformative. It's very, very simple. Good clinicians, good GPs try to do this every day. Good social workers try to do this every day. But it can't be very successful because of the enormous Berlin walls that exist between the health and social service sector, the mental health and behavioral health sector, the housing sector. There's coordination, which is a more structured approach to the kind of ladders that lead over the wall, so you can climb up the ladder and get to the wall and then jump down on the other side. And then there's the mother of all integration, fully integrated care. It's maybe it's a model which is very American because it's one organization is the payer, the provider, and the organizer of the system. It's called an HMO, a health maintenance organization. It's a prepaid, capitation financed entity that is responsible for a fixed group of people. There's compelling logic and theory behind this notion of integration, integrated care. And it's difficult to generalize across the board about the effectiveness of models. Nonetheless, they're all associated with a promising, when they're successful, they're associated with a promising pattern of outcomes, similar kinds of building blocks. One is person-centered focus on frail elderly, but specifically a program that's targeted. In integrated care, it's targeting, targeting, targeting. It's about being very specific of what are the characteristics of the population that you are about to serve. If you don't target well, the most beautiful, the most exquisite, the most gorgeous intervention, the most suave solution to the problem won't work. Secondly, responsibility for identified population and or geographic area, including a single point of entry. So there's discussion about how you are going to target these populations. Are you going to enroll them, roster them? Is it a geographic approach? Is it becoming a member? Case managed interprofessional team care in a coordinated manner. Nick and our project from Aetna Foundation is about care coordination. This is extremely important, whether it's an individual care manager or whether it's a team of case or care managers is not so important as long as there is someone who owns the patient and is responsible for them throughout the system. GP involvement, preferably an active role in some of the best designed projects where the GP copped out, or where the GP couldn't be engaged, or where the GP couldn't be found, or where they were missing an action, or nobody thought that they were really important. They ended up being disasters. Direct control of a broad package of services, not just medical care, but medical and social care and behavioral health care. Organized network of providers, heavy emphasis on service and clinical integration, a common organizational umbrella or a home, alignment of financial and other incentives, and funding flexibilities are important. It doesn't have to be capitation. It could be funds pooling or single funding envelope. And I know the King's Fund is now looking at all kinds of interesting models in English NHS. And final thoughts. Forget about one-size-fits-all integrated care. It's about taking what we know about successful integrated care and figuring out how to plop them into models that make sense for a particular region, for a particular group of people. It starts from where you are, the tipping point question. Why do we do capitation in the US, and why does it scare the hell out of you in England? And it's because we're different places, and it may very well, you may come to capitation one day, but you have to begin where you are. Success demands, oh, this is interesting, social entrepreneurship, innovation, and risk-taking. Some of the most interesting innovation in the United States was led by provider organizations. We don't wait for the government to tell us what to do. Specialize, don't generalize. There are places around the world that are looking for one model of integrated care for everybody. I'm not trying to be a bad boy here, but size does matter. We know that there are limits to how many people, care managers, health care coordinators can serve and be able to do a good job, serve the client or patient or user well, but also do all the kinds of things that ensure there's coordination and cost effectiveness and quality. Focus on outcomes, not costs. In America, we always began with costs. Save money, and hopefully we get to a better place for the patient or the client. And indeed, my experience in the US now and all throughout the world is focus first on outcomes, and if you do a good job with outcomes, you're going to do a good job with costs. There's no question about it. There's a relationship between the two. They're not two parallel pathways. Support the development of integrated health information systems. You can't do this kind of stuff without having information. And then finally, step up education and training activities and integrated care at all levels. We probably wouldn't need integrated care if we had a system which was rational. It was healthcare, not medical care. We say healthcare, but it's a medical care system. And it's the language of medicine. It's the payment systems that are dominated by the medical concerns. It's the institution that's the flagship. The hospital is the flagship, the center of the system, the most powerful, the most visible. We need to begin to change the knowledge base, how we train physicians, GPs, and nurses and other people in the health system about what this thing called integrated care is, what the tools are, how to work better in teams, how to manage chronic illness, and how to build better systems that really provide excellent care to these complex patients. I'll stop there.